prevailing and teaching on vestibular disorders in Mexico, and perhaps this also applies to Latin America. In fact, vestibular and oculomotor disorders teaching in the world is not optimum. There are several objective elements to share what is the current situation in Mexico. I would like to start by asking you to participate briefly. I will be brief, no more than 15 minutes. I would like to hear from you and to help me during this session with your help. Please see here this clinical history. Two females, same history, about the same time with vertigo when they go to bed. They have a vertigo attack when they lie down, then they get up, this goes away. Both are young women, and this is a very similar history. Let's see the first video, please. Right whole pipe maneuver is done. Please, anybody. What do you see here? Any volunteers? Eloisa, can you tell us what you saw here? Well, this is patient number 1. Geo or agiotropic nystagmus. Do you think geotropic? Once again. In positional maneuver, she gets dizzy, vertigo upon lying down. And what's the diagnosis? What happens here? Diagnosis? What's your diagnosis, please? It is not downbeating. This is positional nystagmus. This is not downbeating. Benign. BPPV. Are you sure? Once again, female with vertigo when lying down, we do the whole pike maneuver. Diagnosis? They said yes, both. They both look very much alike, but case number 1 is central positional vertigo. There is vestibular migraine in this patient, but if we don't know the pattern for the eye globe rotation, we may confuse this with BPPV. It does not follow the first law of equal. Well, we see the second case. No, first law of equal says that the ocular movement will be beating on the plane of the canal. This is the opposite in the first case. This is a neurological case, and this is a peripheral case. Those fine details is what I wanted to share with you in order to see from the beginning what is the deficit and the information we are lacking in our teaching from the time we are in medical school. Vertigo and dizziness are a public health problem. 30% of us sitting down here will suffer from vertigo at one point in our lives. Then this is a public health problem. The annual incidence increases with age, and this increases risk of falling down after 65 years of age. What has happened with neuropathology and vestibular disorder over the years? Each one of the disciplines involved has a very individualized viewpoint as an island. Pathologists have a viewpoint where if you go to an otologist, then this otological disorders goes up. But if neurological diagnosis is made, then it focuses more on neurological disorders. Vertigo can no longer be, and this has been seen with the professors we just heard, this can no longer be an isolated entity. This needs to be communicated where each one of the specialties is in communication with the other specialties, or else the patient and our practice will be doomed to failure. A neurological center, which is not considering all 4 or 5 most important specialties simultaneously at the same time, not as an interconsultation, and on the side, a center, neurological center. Otherwise, we would be getting biased diagnosis. This is what Dr. Strop showed us. See the importance of diagnosis group, of course. Once again, BPPV continues to be the number one. But after BPPV, what is the second leading cause? These are about 18,000 patients, one of the most important centers of neuropathology in the world. This is very trustworthy information. Somatomorphic disorders. You can think if your statistics are in regards to this or not. And after BPPV, phobic postural vertigo may seem crazy to be the next cause. If not, you have to review your pathways and your diagnostic criteria. Vertigo and dizziness patients are also patients that belong to everyone and to nobody. Vertigo patient is not popular. Nobody wants to get a patient with vertigo. The audiologists, otologists, in the end, they all go to the psychiatrist by exclusion with the diagnosis that, well, this is aimed and without connecting the information for, well, we can get up to 90% of the right diagnosis on the patients. Unfortunately, vertigo and otological patients fall between otology, neurology, and psychiatry. A patient, it's a comorbid patient. It is not easy for the patient to find a physician looking at the different clinical areas in a competent manner. It is not easy. It is not the same colleagues if you are part of my same specialty to do autoneurological studies without touching the patient and issuing a report with neurohistography or with a conscientious assessment. If you are pleased with just being a cabinet doctor, cabinet doctor, well, it's okay if you don't want to go further, but do not issue a diagnosis. In medical school, it is assumed that the vestibular and oculomotor systems are very complicated to be of practical interest, and few professionals in the population. Many patients with vertigo, no single specialist, neurologist, audiologist in your population or in your city. That is terrible. Very limited knowledge, obsolete information for medical care. In graduate studies, the situation is even worse, because in graduate studies you learn in otorhinology traditionally with some old vices from titular head professors, and you're learning from your own residents. For many doctors, if they say, I get dizzy when I move my head, it is a synonym of what diagnosis? BPPV. That's not the case. You know, benign paroxysmal positional vertigo. We're all, well, taking into account Ewell's first law. This is a problem which gets worse in graduate studies, even if there is a graduate studies course which sees this issue and entity integrally. It is difficult. I may not say it is non-existent, but I've seen enough to say that it's hard to find such a course. In graduate studies, in graduate school, well, taking the chance that we can speak, when I was a resident, we were taught that BPPV was that which wakes the patient up at nighttime. We know this is not the case. This myth has to be done away with. Like the first patient, this patient was totally terrified because of vestibular migraine, central vertigo. In the graduate school, the thing is even worse. See how many specialties have to participate, and they do not work together. Audiologists to the otorhinolaryngologist. The otorhinolaryngologist sends him back, and the patient gravitates from one place to another. No one has the interest in this patient. This is changing. What I see today, and my experience in the continuing education centers, is that this situation is changing. There is high dependence on instrumentation for diagnosis. If you believe that you do not have a VNG or a DG to do the diagnosis, now you know this is totally wrong. VNG and ENG do not do the diagnosis. Not even are good to document this. This is just to keep on the tradition that the patient has to be connected with the ears regardless of what he has in terms of dizziness. This is not the case. I hope after this masterclass you are convinced of that. In case, well, I'm sure you already knew that. Few clinical skills to determine the topography, central or peripheral of the patient in mandatory situation. What is more important in otorhinolaryngology regarding vertigo or dizziness? Where is it located? And next, if there are not firm clinical tools in the practitioner, the first is not complied with, and then the rest is degraded. The rest is degraded, or the use of the useless drug. I will not mention any drug names. This is a master class sponsored by one pharmaceutical. I will not talk about drugs, but you know that the careless use of drugs without the diagnosis, and you already heard Professor Strupp, diagnosis with the drug does apply, because we are impacting the pathogenesis, and in the end we have no diagnosis. There is no diagnosis, there is nothing, because we will be only dealing with symptoms. What for? It is not the same abdominal pain because of gastritis or because of cancer. Both give you stomach pain, but the differences are obvious. Medical specialties in Mexico with the curricula focuses more on vestibular. This is audiology, otoneurology, and so on, otorhinolaryngology, neurology, and it should also include psychiatry, and this is not the case. This is the PUEM of Neurology of the National Autonomous University of Mexico as of 2009. This has not been updated on the website of UNAM. This is what we have regarding otoneurologists in order to train the general otoneurologists. This is endorsed by the National University. And the curriculum for otorhinolaryngologists, what you have here highlighted in pink. Is this true? Is this truly the situation at present? This is for my specialty. This is a specialty that, well, covers 4 disciplines, and each one of them requires 1 or 2 full lives in order to comply with it. Do you agree, Mario? The PUEM, Medical Specialties Curriculum. How can we comply with our objective? I am criticizing myself. It is nonsense what we have currently, and this is the objective of what we are trying to have for those who study this. Obviously, the breakdown is also important. The vestibular system, it is a highly complex system. See the interaction. It has among it not only the labyrinth, parieto-insular region, the medulla, and all the other entities. But this is changing. In the world, there are 5 countries that have shown this is possible. And this is where every patient with dizziness would like to live, particularly a patient with a permanent or chronic vertigo, because this is where they find the way where they can be treated. So, South Korea, Johns Hopkins, United States, Germany, Munich, UK with Brosner and his team, and Australia with Mahari and his team. In Sydney, this is the website of the Integrated Center for Oculomotor and Vestibular Diseases in Disorders in Munich. Visit the website, you will be highly inspired, and at the same time you will also feel maybe ashamed. Well, it's what we don't have here, but there is no dizzy patient if the center was not integrated by all these specialties in Munich on the site, not as interconsultation, but on the site. That is what true integration. See what Mayo Clinic went through before they established the integrated program in 2008. There were several things going on. Care was in 3 stages: peripheral sensory, afferents, central vestibular processing, and behavioral system. Before 2008, 25% of patients in Rochester were leaving the hospital with a report there is no cause detected. 25% had no diagnosis, and that's how they were released from the hospital. Things change. Now Scott Ager's group comes in the Mayo Clinic, Hookerstein, and all these professors who look into the past and see what's going on here. There is an integrated model established, and as of then, less than 2% are released without a diagnosis. And the statistics is more similar to Sydney Hopkins, Munich. Chronic subjective dizziness and vestibular migraine are cause number 2 and cause number 3. Before, they were not diagnosed because this was not an integrated approach. See what happens again, the same above. Before 2008, 25% of patients had no diagnosis, and now with neurootological practice, only 10% are released without a specific diagnosis. It doesn't require a lot of care, just training and the service of a psychiatrist or psychologist. The neurologist doesn't have to be an otologist, nor the other way around, but we need to have the knowledge, cross knowledge, or else this doesn't work. Also, we need to have openness. We need to be humble. We need to have the partnership of specialties, the fact that we have departments with with attitudes and mindsets which are separated is bad for everyone, particularly the patient. And if you have the possibility to change the situation because you have residents under your supervision, you have the obligation to foster a change. There is no choice. This is mandatory. Particularly here, we have some department heads, course heads, joint professors, or people like myself who receive residents continuously. This is an ideal formula. Every time I have the impression, because this is a reflection, that things can improve in this partnership. The surgical treatment in neuro-otology is minimum. Sometimes we believe it is the other way around. This is not the truth. There are training neuro-otological programs. There is a surgical burden, which is huge. This is good for the skills, but diagnoses are biased. Challenges to instill awareness of the importance to do the specialists to do clinical examination to promote participation of those involved in approach between academy and specialists, and also a collaboration with psychiatrists who help you to determine somatomorphic disorders, but we can also perfectly use antidepressants, anxiety drugs, and we have some other things. Why can't we do this if we are not psychiatrists, to have a uniform diagnostic standards? For vertigo, it is easy. Vertigo becomes easier. There is a social, economic impact, but a long time this surpassed otology, from where neuro-otology was born in the 70s. We need to have a communion. No specialty is more important than another. We need to have a partnership between specialties. This requires a review, modification of the curricula in all areas. This has to do with the university authorities for their curricula, involved reflections upon this, and trying to foster those, if you are part of the review committees of the single specialty programs. David, Dr. Z, can you help us diagnose this patient, please? Si nos ayuda, doctor Z, a hacer el diagnóstico de este paciente, por favor. Buen diagnóstico. Una entrevista exclusiva con Hillary Clinton, que está ahora en los encabezados, donde se le pregunta sobre asuntos médicos después de que los estrategas hablan de que se ha sugerido, y esto puede haber que haya habido una persona que sufrió de un daño cerebral. ¿Cómo fue? Bueno, fue algo serio, creo que fue una concusión muy seria la que sufrí, y debido a la caída, bueno, tuve una visión doble, y bueno, pero ahora me encuentro perfecta. No ha habido ningún efecto secundario que permanezca. But still there is a mystery without being resolved yet. So there are mysteries such as this.